kita angkat je. Okay, fine. So there should be three seminar, three topics for this seminar. Cannot remember siapa yang patut present. Should be three of you kan? I'm sorry, I can't really
Four. Four per presenter.
Four presenter.
Ada 4 topics.
Okay, fine. It's just I can't really focus on my work for the time being. It's been a very busy week for me. Anyway, so I'm just going to check. So 29. It should be 29 ke 30? Should be 30 people, 29 people. Anyway, that's fine. So it should be. So this is a topic where it's about developmental ataupun it's more towards endocrine topics, and so before presenters, the first one should go first is it Douaa or is it Amirun?
Douaa.
Okay, if that's the case, then so I'm just going to invite Douaa to present your topics. Hello?
Can everyone see my slide?
Yes.
Yes. So I'll be starting presenting with pubertal development and staging. Is my tone loud enough for everybody?
Yes.
Okay. So we will be talking about puberty today, and it's basically how our bodies change as we're growing older. So we'll be comparing how the females grow and how the males grow to each other. So we'll start first by defining first what is puberty. So puberty is a reproductive process, and it's when the child finally starts to develop sexual maturation and changes from being a child into an adult. And during that time is when the child develops secondary sexual characteristics. So the onset of puberty in males is commonly between 11 to 14 years, while in females it's between 8.5 to 2.5 years old.
So I'm just going to stop you there. I just want to, is everybody can see the slide, or is it just half?
Oh, I think I see half.
It's half? Okay, sorry. I thought you were looking at it full screen.
There you go. Fine. All right, carry on.
Is it full screen now?
Yeah, I think everybody's satisfied in it. Yeah.
Okay.
Yeah.
Okay. So over time, it's been noted that the mean age in which puberty starts in girls has lowered, but the age of menarche has been relatively stable. So that kind of concludes into females remaining in the puberty stage of life a little bit longer. However, it's important to note that both sexes during puberty will experience acne, axillary hair growth, body odor, and mood changes. And the next point is for a little bit later, when you have to note that sex steroids that our body produces are the cause of fusion of our epiphyseal plates, which means our sedation to grow in length. So we'll start with gonadarchy, which is basically puberty in females. So puberty in the gonad. At 1 to 3 years old, before the onset of puberty, there's usually low serum LH during sleep, and these increase because there will be a secretion of hypothalamic gonad releasing hormone in a pulsatile fashion. So this pulsatile secretion of gonadotropins causes the enlargement and maturation of the gonads, and thus will cause the secretion of sex hormones. In early pubertal secondary sexual characteristics, when these are developed, it kind of indicates to us that there is sustained active interaction among the hypothalamus, the pituitary, and the gonads. So in mid-puberty, the LH levels will be evident in the daytime instead of just during sleep. So the activation of gonads by FSH hormone and LH will eventually stimulate the production of testosterone and estrogen. There's a diagram that will help explain this after this. So adrenarche, in adrenarche, the difference is that DHEA and its sulfate begin to increase before there's an increase in LH receptor hormone. So single measurements are usually used as a marker for adrenal androgen secretion of DHEA. So effects of gonadosteroids such as testosterone or estradiol are critical in bone growth and osseous maturation, which we mentioned earlier in our first slide, because these will cause the epithelial plate to finally close and thus ending the growth sprout. So an increase in production of androgens by the adrenal cortex is eventually what leads to pubic hair, ectodermy, body odor, and acne. So just to explain this better, this is the diagram. So at the beginning, let's say at approximately 8 years old, the hypothalamus will increase the production of gonadotropin releasing hormone. And it's also important to note that before puberty, the hypothalamus and the pituitary are very, very sensitive to negative feedback from testosterone and estrogen. As you grow older, or as the child grows older, the sensitivity kind of decreases, and that's why there will be increased levels of estrogen and testosterone. So the releasing of this gonadotropin releasing hormone to the anterior pituitary is what releases the LH and FSH. The release in LH and FSH will trigger testosterone production in the testes and estrogen production in the ovaries. And then we get to see the effects of the sex hormones that are being released, such as ovaries, breast development will happen, hips will broaden, there will be pubic hair. For males, penis and scrotum will grow, there will be facial hair, they will have a deeper voice or like voice cracking during that time of puberty. Their shoulders will broaden and they'll grow body hair as well. So we'll start with girls. So what happens during puberty in girls? They might get taller, their breasts begin to grow, their hair grows in their armpits and on their legs. May get pimples, sweat, body odor will become a thing, and then menstruation will happen, and that usually marks the end of puberty. So the first stage in girls is usually the breast bud, which is alternatively called stellarchy. It happens between the age of 8.5 to 12.5 years. Immediately after this breast bud grows, there will be growth of pubic hair and there will be a growth sprout in females. Pubic hair alternatively is called pubarchy, and as I mentioned, it's almost immediately after breast bud growth. After the pubic hair and the growth spot, then there will be the onset of menstruation, which is menarche. Typically, it's after 2.5 years after puberty starts, which means after the breast bud has started to grow, and it signals that growth is coming to an end, which means that they have about 5 centimeters left to grow, and then you have others. So stellarchy, which is the stages of the breast growth, in stage 1 is prepubertal. So as you can see from the side profile and the front profile, there's almost no breast blood flowing. Stage 2, there is early puberty, which you can see that there's a little bit of a breast blood. As we move on to stage 3, that is mid-puberty, which means the breast bud is enlarging, but there's no separation in contour between the breast, the areola, or the nipple. As we get to stage 4, in advanced puberty, there will be separation in contour between the areola and the nipple of the breast. Stage 5 is an adult size, yes, with complete development, whereby the nipple will project and the areola will be part of the breast contour. Then we go on to puberty. So in stage 1, basically there will be no indication or no separation between the type of body hair that is found over the pubis or the pubic hair and over the abdomen. So it will kind of be just as hairy as that baby was from, let's say, middle childhood. As we get on to stage 2, there will be sparse growth of long, straight, downy hair. And then in stage 3, the hair gets darker, coarser, curlier, and it will spread in the typical female triangle. Stage 4, the hair becomes denser, and in stage 5, the becomes larger in quantity, and it can spread to the aspects of the inner thigh. So before we go on to boys, are there any questions about girls?
Douaa?
Yeah.
Yeah, I'm sorry, but can you try to adjust the mic because you sound a bit of robotic.
Oh, sorry. Let me try to not use my headphones. Maybe that'll be better. Can you hear me better now? Maybe?
Yes, maybe try to raise your voice.
I'll try my best. It's an old laptop and I'm not using. So moving on to boys. If you can't hear my voice, please feel free to stop me at any time. So what happens to males during puberty is that their voice deepens, the armpits start to sweat, body odor becomes a thing that you cannot tolerate anymore. Hair grows on their face, their chest, their arms, everywhere. Boys get taller and their face may get pimples, and as well as their privates will enlarge. So what happens first for boys is that testicular enlargement and thinning of the scrotum is what is the first stage in puberty. So the testicular enlargement will typically be over 4 milliliters, and it's usually measured by an orchidometer. This is the orchidometer. So in childhood, it's usually up to the third ball or the third 3 milliliters, and then early puberty is usually about 4 to 9. Sorry, mid puberty is 8 to 12, late puberty is 12 to 15, and adulthood is about that, like 20 or 25 milliliters. So after testicular enlargement, there will be pubic hair growth or puberty, and then axillary hair growth. This usually will start at about 10 to 14 years, and then there will be a growth spurt. So this growth spurt typically happens when the testicles have enlarged to 12 to 15 milliliters, and there's usually a delay of 18 months between that and the previous stage, which is the pubic hair and the axillary hair. So you see here in about 12 to 15 milliliters is late puberty. And it's important to note that in males, the growth spout is completely different than females. And because it takes longer, that's why they grow taller than females. So in males, first, in stage 1, we have the penis, the testes, and the scrotum, which are at the same size as they were in childhood. But as they get to stage 2, there will be enlargement of the scrotum and testes. Only in stage 3 is there an enlargement of the scrotum, the testes, and as well the penis. In stage 3, the penis will enlarge in length, while in stage 4, although the scrotum and the testes are also enlarging, the penis will enlarge in breadth this time, which is like width or thickness of the penis. And as they get to stage 5, the genitalia is of normal adult shape and size. So when we talk about male hair growth, it's almost the same as female. Stage 1 is not included because it's the same as childhood. Like you cannot differentiate the hair on the pubis from the hair on the abdomen. In stage 2, there will be like slight growth of hair, slightly pigmented, straight or curly at the base of the penis. And in stage 3, the hair then goes darker, becomes more, and spreads. And then it's spreading until it extends into the thighs. So this is just a comparison between the hair growth between the males and the females. It's commonly the same thing. Sparse and then gets more and then spreads but not into thighs and then spreads into thighs. So that's the end of my presentation. The rest will be continued by my mates. Any questions?
Okay. Anyone got anything to ask? Basically, what Douaa was presenting about the normal physiology in terms of normal staging of puberty. Yeah. So so if you got somebody who, you know, let's say if a girl had a menarche too early, before the age of 8, or whether the menarche more than in the age of 13, 14, then it's not to worry. So that's when the problem arises after that. Same as a boy as well. So normally in a boy, it's not much about menarche. It's about short stature. So that's a main thing about boys. So boys, you notice any pubertal problems is mainly due to the short stature. So that's the main presentation in boys. In girls, it tend to be either early menarche, which is precocious puberty, or late menarche, which is delayed puberty. So that's why you see more pubertal problems in girls rather than in boys, because there's not much in terms of benda yang quite alarming for boys, apart from being short. So being short, if you are 11 or 12 and you look very short compared to your peers, compared to your juniors at schools, then you worry about possible your pubertal stages is not following the normal process. In girls, is mainly menarche, is it early or too late? And sometimes in girls, the pubertal presentation, something you can have early pubic hair growth in girls. So I've seen early pubic hair at the age of 18 months, 2 years. So it's just something, some sort of pubertal issues that need to be sorted out, because it could be tumors in the brain, or it could be some sort of secondary precocious puberty that need to be sorted out. Okay, so those are just a normal pubertal staging that Douaa was presenting. So then it will come the problem after that. And so the problem after that is going to be delayed puberty. So delayed puberty is going to be presented by Idlan.
Me.
Okay, so.
Okay. Okay. Can you see my slide?
Yeah.
Yes.
Full
Yes.
Okay. So my topic for today is delayed puberty. So this is my outline. First is the definition, epidemiology, etiology, approach, which is clinical features, and also management. Okay, so what is defined by delayed puberty? So from the illustrated textbook of pediatrics is defined as delay of absence of pubertal development, 40 years old for female, 50 years old for males. In Nelson is quite different, which is 30 years old for female and 40 years old for male. And on Islamic perspective, like balik that we learned from primary school, the balik age is around 9 to 12 for female, 12 to 15 for male. That's what we learn lah. So more than that is considered delayed puberty lah. Alright, so epidemiological speaking, so delayed poverty is occur, this I get from up to date. Delayed poverty occur about 5% in a given population. So it's more common in male per se rather than female. And if delayed poverty happen in females, we must rule out organic causes first. And for your information, secondary hypogonadism is more common than primary hypogonadism. So let's talk about the etiology. So basically, I divide into primary hypogonadism and secondary hypogonadism. So it can be further divided into congenital or acquired, same as secondary hypogonadism. So what is the meaning of primary hypogonadism and secondary hypogonadism? Is that in primary hypogonadism, the problem is occur in the receiver part, which is testis. So when this part become problematic, so there will be no production ataupun lack production of testosterone. For secondary hypogonadism, they will be in higher center lah, whether hypothalamus or pituitary. So when there is no this hormone, these three hormone, so there will no stimulation on the testis and also ovary. So there will no production of testosterone and also estrogen. Okay, so this is the causes of the primary hypogonadism, or also can known as hypogonatropic hypogonadism. Means that there is more GnRH, LH and FSH hormone, but lack of the testosterone or estrogen hormone. So for congenital, it can divide into first chromosome abnormalities, which is more on genetics. First Turner syndrome, 45XO, common is all in female. While Klinefelter syndrome, all in male. Then anorexia, which is absent of the testis. For acquired, can be autoimmune or post-infection that can cause trauma to the testis or ovary itself. Trauma or surgery, and also chemotherapy and radiation therapy. Alright. So for secondary hypogonadism, also known as hypogonatropic hypogonadism, because it's they absent in the higher center hormone, so there will be lack of testosterone and estrogen after that. So congenital can be Kalman syndrome, which is isolated genetic deficiency, and then if associated with mental retardation or obesity, can be Lawrence Moonbill syndrome and Prader-Willi syndrome. And the idiopathic form of multiple anterior pituitary hormone deficiency is idiopathic lah. And then congenital brain malformation causing gen RH and also gonadotropin deficiency. So for this patient is usually have craniofacial anomalies. So acquired can be functional, or we call as physiologic gonadotropin deficiency. For example, constitutional delay of growth and puberty, which is the most common type of delayed puberty, CDGP, and other causes such as chronic systemic disease, acute illness like SLE and any chronic system disease lah, malnutrition, anorexia nervosa, and also bulimia, and other metabolic disorder such as hypothyroidism and so on. And then tumors can also cause secondary hypogonadism is here in at the higher center. And then infiltrative disease, if infiltrate the hypothalamus and pituitary, head trauma, and also pituitary apoplexy. Okay, so this is the simplified etiology that I take from illustrated textbook is the same, primary and also secondary. So let's talk a bit about the some common causes of the etiology. So the common causes is CDGP, like I said before, is a transition functional defect in production of the hormone from the higher center due to maybe in genetic lah. And this diagnosis is diagnosis of exclusion. And it's more common in male to have CDGP than female. That's why in male, can suspect CDGP, but needs to exclude the other hormone and a genetic problem lah. Okay. And 50% of the CDGP have family history of delayed puberty. If you clock this patient in the history, there will be the family of short stature, like his father or mother have some delay in puberty. So this is familial punya causes lah. And then PE, usually there's not so much aspect of short stature. The cardinal diagnostic to diagnose CDGP is by bone age itself. We can compare with the normal age, there will be delays. And usually it doesn't need intervention, but reassurance to the child that this is physiologic causes lah, not pathologic. Okay. Next one is Klinefelter syndrome. It's a primary hypogonadism. So this is the most common part of primary hypogonadism and also infertility in male. And usually not been diagnosed lah. And the prevalence is about 1 to 2.5 per 1,000 boys. And from the history, because it's involved genetic, it might have the dysmorphic features such as gynecomastia, small film testis, and also have reduced intelligence and delayed puberty in the history. So to diagnose genetics, it's only need genetic karyotyping or specific chromosome karyotyping lah. And the management would be testosterone replacement therapy because Klinefelter only in male. So next, Turner syndrome, the disease of the genetic disease for female, is also quite rare, which is 1 in 2,000. And the two most common features of Turner syndrome that we can observe in our examination is short stature, which is the limbs is more greater than the trunk, and we can also observe ovarian insufficiency in this patient. And also in this picture, you can see that they have some buffalo hump, big neck, and also some features of acne. Okay. Diagnostic also same as Klinefelter is chromosome karyotyping, and the management also the same, which is estrogen replacement therapy started as age 12 to 15 years old. Okay. Next is Kallmann syndrome, which is secondary hypogonadism. And this Kallmann syndrome usually it can be combined with anosmia, with absence of sense of smell. So prevalence is approximately 1 in 10,000 men. And it can occur both in men and women lah, but the data I only get for men. Okay, so for men, so symptom like say before can be they will decrease libido, erectile dysfunction, they will be decrease in muscle strength. Lepas tu for the management for male, it can induced by the testosterone therapy lah, hormone therapy. And for women, it can have amenorrhea and also dyspareunia. The management also the same, which is exogenous estrogen to start the secondary sexual development for puberty. Okay. So this is the picture of the summary of the Kallmann syndrome. Okay, you can read it later. Okay, so for the approach to the child with delayed puberty, from the history itself, we can, from the medical history, we must rule out the other causes lah instead of CDGP, and so we can rule out the patient have trauma to the head injury, have any systemic illness at that time, medication, for example, chemotherapy, radiotherapy, also can disrupt the testosterone ovary, infection, malnutrition, autoimmune disease, and so on lah. For the review of symptom, if the patient you might suspect have these syndromic features, they might have inability to smell, anosmia in Kallmann syndrome. Yes, age at onset of androgen sign, which is puberty sign lah. Yeah, and also small genitalia at birth, sign of primary adrenal insufficiency. This is the metabolic causes. Need for deodorant. I'm not sure which disease that they have like need for deodorant because of the smell of their body. Okay, for family history in CDGP, you might want to ask if there is family history of delayed puberty, whether in first and second degree lah. Okay, for physical examination, for general inspection, there'll be you can observe dysmorphic features, any signs that suggest of chronic disease, and vital signs, anthropometric measurement. So usually the delayed puberty has short stature, and then there will be any ability to smell in Kalman syndrome, and then you can go specific to the development of the puberty itself, such as for female breast development, and for male testis and also penis pubic hair development. And then some syndrome also cause defect in the neurological examination. So you might want to do neurological examination to know is any intellectual disability. Things and also visual part. Okay, this physical examination. Then for the management wise, so I take from Nelson, they give the algorithms first specific to the gender. So first we look to boys. So like I said, in Nelson is more than age 13 years old, right? So the first one we want to measure the serum gonadotropin because we want to differentiate whether it's primary or secondary causes. So if the serum gonadotropin increase, it shows us that it most likely to be secondary causes because the response of the no because the response of the testosterone toward the hormone is like okay. So and then when we suspect serum gonadotropin elevated, you want to do karyotyping to whether if male you do to check for any Klinefelter syndrome. Then if normal, let's say it's normal, so it might be the testicular failure lah. And then if serum gonadotropin is low, indicate of secondary hypogonadism. So you might look to the growth pattern. So if the growth pattern, if you in CDGP, you do bone age scanning imaging. So if delay, so it's CDGP. And if otherwise, if normal without any short stature so on, you might want to test for the anosmia for indicator of Kalman syndrome. Okay, I think that's all for and also rule out any tumor lah. Let's do MRI to look for any mass in the brain. It specifically involve hypothalamus and also pituitary. So this is for the boys. For the girls, so it's also the same. You look for any first serogonadotropin. If elevated, so you proceed to karyotyping. It's most likely to be the primary hypogonadism to rule out any Turner syndrome. If not, it might be other causes lah. If normal in karyotyping, and then if serogonadotropin low, secondary gonadal hypogonadism. So you look at growth pattern. It's same. If delayed, if short stature and during the scan is bone age delayed, so you can diagnose CDGP. And if normal but without growth any spurt, so you can detect of anosmia to rule out Kalman syndrome. Do MRI for look for any mass in the brain. That's for algorithm for investigation, also some management. So for the treatment wise, like I said before, if it's physiology, it's CDGP, usually we do watchful waiting until the puberty come. Like we can expect from the parent itself, like parent have puberty at the age of 60 years old, so expect 60 years old of the puberty. Then for the part, I think for the if other causes, whether primary or secondary, we usually go give the hormone therapy lah. For male testosterone, for female estrogen. I think that's all from me. Thank you. Any question?
Okay, so delayed puberty is more common in basically in boys. Precocious puberty is more common in girls. Okay, so delayed puberty. Why it's more common in boys is because that we tend to make it quite take it for granted for boys. So that's why boys tend to come in very delayed puberty, and delayed puberty normally come with short stature as well. So sometimes if you find the causes of the delayed puberty, you also noted that the child normally quite short. As soon as you correct the causes of delayed puberty, then you will see the improvement with their sexual characteristic, secondary sexual characteristic, and also you see the improvement of the height once you start treatment. So puberty is not that easy to diagnose anyway. So normally you go for hormonal testing first. So you go for gonadotrophin testing. Depending on that, then you do the MRI brain to see where exactly the causes of the delayed puberty. So if it's primary, then there's not much you can do about that apart from give gonadotrophin supplementations. If it's secondary, which is the pituitary, the causes, then it could be due to tumors, it could be from the previous infection, it could be because of the hyperplasia of the pituitary and so on. So depending on what it is, then the treatment will be depending on the pathology. But otherwise, if it's primary, then it's just supplementation of hormone. So primary is not that common anyway. It's more common in secondary delayed puberty due to subsequent due to a complication from the initial problem. So if you got meningitis when you're small, so sometimes meningitis can affect your pituitary and also your hypothalamus, then that will lead to the secondary delayed puberty. So those are the things that you need to look for. Okay, any question? Okay, so this is delayed puberty. So once you finish the topic for delayed puberty, then you come to the diagnosis. You come to another topic called precocious puberty. So one is delayed, and the one is going to be the puberty is come too early. So the one that's going to present the precocious puberty is going to be Alya, isn't it?
Yes, Doctor.
Okay,
Yes, Doctor.
the floor is yours.
Okay. Can you see my slide?
Yes.
Okay, Assalamualaikum warahmatullahi wabarakatuh. So my name is Alya. So I will present about precocious puberty. So precocious puberty can be defined as a secondary sexual development occurring before the age of 9 years in boys or 8 years in girls. So the overall incidence of this secondary of this precocity is estimated to be 1 to 5,000 to 1 to 10,000 among children, and it is more common in female compared to male with ratio 10 to 1. So the risk factor for this precocious puberty is being a female, obese, having any medical condition like congenital adrenal hyperplasia, hypothyroidism or any CNS lesion, or having history of received radiation therapy to the cranial nerve, CNS. Next, for the classification, precocious puberty can be divided into central, or also known as true or GNRH dependent precocious puberty. Second is peripheral or pseudo or GNRH independent precocious puberty. So other than these two, the other variant is also called as benign or non-progressive precocious puberty. So for the central precocious puberty, the main causes is due to premature activation of the hypothalamic pituitary gonadal axis. So in this type of precocious puberty, there will be normal sequence of pubertal development, or also known as consonant. And then the other type is peripheral precocious puberty. The main causes is due to excess sex steroids outside the pituitary gland. So in this case, there will be abnormal sequence of pubertal development, or also called as dissonance. Other than for benign, there is usually the three type, which is premature dilarchy, which is breast hypertrophy before puberty, and then premature adrenarche, and isolated premature menarche. So this is basically about how it happened for gonadotropin dependent type, or also known as central precocious puberty. There will be overproduce of LH and FSH by the pituitary gland. So this LH and FSH then stimulate the gonad, so the gonad will enlarge, and then the mature gonad will produce their hormone. For example, for ovary, we produce estrogen, which lead to breast enlargement, and for testosterone, uh, we, testes will produce testosterone, which lead to pubic hair growth, acne, or any body odor. The second type is gonadotropin independent. So in this type, compared to the dependent type, there will be low FSH and low LH. So in this type, there will be gonadal and extragonadal produce excess sex steroid hormone. So it will produce estrogen, will stimulate breast enlargement, and testosterone stimulate the pubic hair growth and so on. And this high amount of estrogen and testosterone will causing negative feedback to the pituitary gland, which lead to low LH and low FSH. So for the causes, it can be divided into GnRH dependent or GnRH independent. GnRH is the central type, and the independent is the peripheral type. So for the central type or GnRH dependent, the most common cause is idiopathic. So usually idiopathic and more common in female compared to male. And second, it can be caused by genetic mutation of any gene that involved uh, in the pathway. And then third is CNS lesion like any hematoma, CNS tumor like astrocytoma, ependymoma, and his previous CNS irradiation, other brain lesion like cyst, hydrocephalus or trauma, and lastly pituitary tumor. For GnRH independent or peripheral precocious puberty, the causes for female, it can be caused by ovarian cyst. The most common one is functioning follicular cyst, and then second is ovarian tumor, which can be granular cell tumor or Sertoli or Leydig cell tumor. If the female have Sertoli or Leydig cell tumor, it will lead to contrasexual precocious puberty. Means that the female will develop the male secondary sexual characteristic. For male, the most common causes is Leydig cell tumor and HCG secreting germ cell tumor. Otherwise, other than that, for both male and female, the causes can be primary hypothyroidism, any adrenal pathology like hyperplasia or tumor, and McCune-Albright syndrome. So for primary hypothyroidism, it is basically due to cross-reactivity and stimulation of the FSH receptor by high level of TSH concentration. So this usually only occur in a severe and long-standing hypothyroidism. So for McCune-Albright syndrome, so it is a triad of preferred precocious puberty, plus irregular cafe outlet spot and also fibrous dysplasia of the bone. So basically what happened in Macon Albright syndrome is there is a mutation of the G protein that form the adenylate cyclase, which lead to stimulation of multiple endocrine organ. So for history, for female, the first and most obvious sign that occur is the breast enlargement, which can be unilateral. And then after that, pubic and axillary hair also can appear, but it also can appear before the breast enlargement itself. And the last event usually the menarche, which occur about 2 to 3 years after the breast enlargement. For male, the earliest evidence is the testicular enlargement. However, this type of enlargement can be unnoticed by the patient or parent itself. After that, 1 year after that, there will be growth of penis. So other history that must also be included is other secondary sexual characteristics which have been explained by Douaa previously, and other features throughout other causes like hypothyroidism symptoms, neurological symptoms, etc. And also we must also ask about past medical history to know any underlying of CAH, hypothyroidism, any brain lesion, brain trauma, or any gonadal disorder, and also any underlying syndrome. And then we must also any previous exposure to radiation on the central nervous system, any past surgical history and family history, because some of the precocious puberty can run in the family, which is the familial male limited precocious puberty. For the clinical features, it's same. For female, we look at if there is any breast budding or enlargement, pubic hair or mild acne. If the female patient have severe acne or clitoral enlargement, you must suspect for androgen access disorder. For male, there will be testis enlargement, growth of penis, pubic hair, acne, voice change, and facial hair. Other clinical features that we must also see is hypothyroidism, like neck swelling, dry skin, thin hair, muscle weakness, edema, and also we must elicit neurological signs if we suspect it is caused by CNS lesion. And then other assessment is pubertal staging, which had been mentioned by Douaa previously, and also we need to assess the height, weight, and high velocity because we want to differentiate between benign type and also progressive type. So in progressive type, there will be early growth acceleration compared to in benign type. So for investigation, the initial lab evaluation first is basal LH luteinizing hormone. So if the level is between if the level of LH within the prepubertal range, which is less than 0.2, it's more suggestive to a preferred precocity or benign pubertal variant. However, if the level is high, it more suggests to the central precocity or progressive type. Next, for basal FSH, usually high in central precocity, and then we also measure serum estradiol or serum testosterone. So if very high, it more indicate toward preferred precocity. And that's we can do GnH agonist stimulation test. So basically, this GnH agonist stimulation test only done if the LH level that we done previously, the LH level is within the prepubertal range, but the child have clinical features of central precocious puberty. So we do this GnH agonist stimulation test to differentiate between CPP, the central precocious puberty, and also the benign type. So what we see in this test is peak stimulated LH, peak stimulated LH FSH ratio, and stimulated estradiol or testosterone. Basically, all of this value will be high in the central precocious puberty. And then the last one is serum adrenosteroid, which are used to differentiate between preferred precocious puberty and also benign pubertal variant. So for there will be high level of serum adenosteroids in precocious puberty compared to the benign type. So other tests that we can do depending on what suspected disease. For example, you can do HCG level to rule out any testicular causes or thyroid function test to rule out hypothyroidism. And next for imaging, we can do ultrasound of abdomen or pelvis or testicular depending on what we suspect. So we can see any cyst or any mass in the respective area. And then we do CT abdomen to rule out any adrenal tumor, and then for MRI of brain to rule out any brain lesion as mentioned previously. And last one is bone age assessment. This is basically to assess the if there is presence of advance in bone age. Usually there will be advance in bone age more about 2 standard deviation beyond the chronologic age in central precocious puberty or prefer than benign pubertal variant, because the central precocious puberty and peripheral precocious puberty is a progressive type. Meanwhile, for the benign is usually non-progressive. So this is a summary, basically what I have mentioned previously. And then for treatment, for pharmacotherapy, for central precocious puberty, the usual drugs given is long-acting GnRH agonist, such as leuprolide acetate, neferelin, or hysterelin. So the action is by suppress the gonadotropin secretion by down-regulating the GnRH receptor in the pituitary. So next for the peripheral precocious puberty, for girls usually given medroxy progesterone acetate, also known as Provera. So the action is it inhibit the action of LH and FSH. And then for boys, we can give ketoconazole, which is an androgen receptor antagonist, spironolactone, which block the androgen receptor, and also testosterone, or letrozole, which is an aromatase inhibitor, which block the conversion of androgen to the estrogen. So for drugs, actually for female, some of the drugs in male can also be given in girls if the girls are presented with contrasexual precocious puberty, means they develop the male secondary sexual characteristics. So the same for boys. If the boys have contrasexual precocious puberty, they can also be given the medroxy progesterone acetate. So next, the last one for surgery. So surgery usually only done if the cause is due to any hormone secreting tumor, either at the brain or adrenal or at the testes. And then for brain tumor, usually we also do the radiation therapy if the surgical resection is incomplete. That's all.
Okay, so as I mentioned before, the precocious puberty also it's almost the same as other elite puberty, and there's also in terms of mana ada primary and also secondary causes as well. And the most commonest cause of precocious puberty it is syndrome as well, and sometimes it could be due to excessive production of the sexual hormone. So that's why you get the patient coming to you with early puberty hair and also early menarche. And I think Alya presentation is quite straightforward. Precocious puberty untuk endocrine is very favorite subject that can come out in your exam as well. Cuma unfortunately we don't really have many patients yang datang yang come to our center with precocious puberty. It's going to be a very good cases but a long case kalau ada patient yang datang. I'm sure that if we have a patient with precocious puberty, that patient will come to final pro exam for a long case period. Fortunately for you guys, we're not going to do a long case for your final pro. It's going to be a modified long case, which is okay, not too bad. Okay, any question about precocious puberty? More next part. I also want to get things finished quickly as well. Okay, then the last one is going to be ambiguous genitalia, which is a quite very difficult subject to discuss, especially if you're dealing with the child during united period. So I'm going to ask Dahiyah, Yang Mulia Tengku Nur Dahiyah untuk menyampaikan ucapan. Dipersilakan.
Okay,
Okay.
thank you so much, Doctor. So, Assalamualaikum warahmatullahi wabarakatuh. Can you all see my slide in full presentation mode now? All right. So, I will be the last presenter for today. So, my name is Dahiyah. Just call me Dahiyah.
Can you make it bigger?
Tak boleh.
Nampak separuh ke?
Tak pernah tapi kecil.
Now? Sekarang?
Besar dah.
Okay. So, I will be the last presenter. I hope you can still bear with me. Okay. So these are my outline for today. I'll start off with a bit of introduction of my presentation, and we go through a little bit of normal sexual development and go into detail about disorders of sexual development, and I'll touch upon some commonest causes of disorder of sexual development and how we approach and manage the ambiguous genitalia. So the importance of disorders of sexual development, it is a neonatal emergency. So based on the PITS protocol, basically this is a new term because previously they call it as hermaphrodite, but we are no longer use that term. So since 2006, it called as DSD, which defined as various congenital condition in which there is inconsistency between the chromosome, which is the XX or XY, and the gonadal, which is the testis of ovary, and the anatomical site, which is the phenotype of the patients. And based on Nelson, the atypical or ambiguous genitalia, which case we cannot define the external genitalia. It is appear completely male or do not appear completely male or completely female. And the commonest causes of disorder of sexual development is congenital adrenal hyperplasia. So why it is being our concern? Because it can cause some medical issues, which is emergency issues, which I will explain more later, such as salt losing crisis, urinary tract infection, and bowel obstruction. And also it involves regarding the decision on sex of rearing of the child. So we want to avoid any wrong sex assignment and prevent any gender confusion. And a bit about psychosocial issues for the upbringing of the child. Okay, this is the normal sexual development. This is just to show how in the intrauterine, in second to third month of pregnancy, we cannot still differentiate the external genitalia of the baby. And at the third to fourth month, some differentiation occur. Okay, so can you still remember the sex differentiation in our previous class in BMS? So initially, the gonads of the fetus is undifferentiated, or we call it as a bipotential gonad. So what happened in male and female development? So the more complex one is the one we have to remember in male development, because what happened? They have the SRY gene, which is only male that have this gene, because it is by the Y chromosome. So the SRY gene will determine the pathway of development, which is to activate the testosterone pathway. So the important cell, the testis development pathway. So the important cells that we have to remember is the Leydig cells and also the Sertoli cells. Okay. So the Leydig cells, it will produce the testosterone, and the testosterone will then convert it into the dihydroxy testosterone, which this is the most responsible hormone that activate the androgen receptors. So what androgen receptors do next is virilization of the external genitalia that we can found in the male phenotype. And also testosterone have a local effect which it cause development of Wolffian duct, and Wolffian duct will later develop into male internal genitalia such as the vas deferens, seminal cord, and seminal vesicles. Okay, the next one, Sertoli cells. So Sertoli cells produce anti-Mullerian hormone, the AMH. So the AMH cause the regression of the Mullerian ducts and inhibits the uterus and also fallopian tubes. Other function of Leydig cell, it also produce insulin like 3 together with testosterone that cause the descending of the gonads in the male. So easier in female development. Actually, what the female have because they don't have what exists in the male. So there are no SRY gene, there are no testosterone, there are no anti-mullerian hormone. So because there was no SRY gene, so testosterone pathway is not activated. So the bipotential gonad will differentiate into ovaries and female genitalia at the 10 week of gestation. And because there are no testosterone, so no androgen receptor activated, so no virilization of the external genitalia. Also, because no testosterone, there is no local effect, which is there will be no development of Wolffian ducts, and the gonads is remain in the abdomen. And when there is absence of AMH, anti-Mullerian hormone, so they will cause the development of the internal genitalia, which is ovary, fallopian tube and also uterus. So this is the development. You can see the internal genitalia and also external genitalia. Basically, what I just presented earlier. So the red one is the Wolffian duct, which is effect of testosterone that exists in the male, and the persistence of Mullerian ducts in the female cause the female internal genitalia development. So for external genitalia, we can see the three important structures: genital tubercle, genital fold, and genital swelling, which will then differentiated according to the respective phenotype, male or female. So genital tubercle will develop into glands, into glands penis in the male, and Y in female develop into clitoris. For the genital swelling in the male, it will fuse and form scrotum. However, in female, it will not fuse and it will develop into labia majora. And the last one is genital fold. Also, in male, it will fuse and develop into the shaft of the penis. And in female, it will not fuse and form the labia minora. Okay, that's a bit about the. Sorry. Okay. Okay. So these are the types of disorder of sexual development. So this is being classified into sex chromosome DSD, 46XY DSD, and 46XX DSD. So for sex chromosome DSD, I think Idlan already tell about the Turner and Klinefelter syndrome. So I'll be focusing more about 46XY and 46XX disorder. And the most common one is in 46XXD is the congenital adrenal hyperplasia. Okay, so this is just a recap about what Idlan has already presented before. So 46XY DSD, the genotype is SY, but the external genitalia either is not completely visualized into male or atypical, both are present, or completely female. And it is not identified in 15% of the case. So the etiology based on the up-to-date, it is due to insufficient DHT, dihydrotestosterone the which is gonadal dysgenesis, which cause underproduction of both Leydig and also Sertoli cells. The second one, because there is a specific defect in the dihydrotestosterone production, such as also CHA, congenital adrenal hyperplasia in male. And the third one is an ability to respond to the hormone DHT and other androgens, such as in the androgen insensitivity syndrome. So, for example, Swyer syndrome, the common cause of the gonadal dysgenesis, and also AIS. So this is AIS, which the male it can there is a defect in the androgen receptor, so they cannot respond to the androgens. So there are partial and also complete AIS, which the partial male can have the normal external genitalia but infertile, but incomplete they may present it with completely female genitalia. Okay, so the next one is 46XX DSD. So in this, they have XX genotype, and also they have gonadal ovaries because there's no problem with the hormones, but they have external genitalia which are virilized. And why ovary gonads is not affected because there are no significant AMH production. Okay. So why this happen? Because of excess androgen action, which due to can be overproduction of androgen by adrenal cortex, such as in the CHA, congenital adrenal hyperplasia, excessive production of the testosterone by gonads, such as in the aromatase deficiency problems, and atopic or exogenous sources of androgen, such as in intrauterine when the mother exposed to the exogenous source of androgen. Okay, I go a little bit regarding the congenital adrenal hyperplasia. So this is a autosomal recessive disorder of adrenal hormone biosynthesis, commonly affected in the genotype of 46XS DSD, and 95% of CHA is due to 21 hydroxylase deficiency. So this is the apa, and then the steroids productions, we can see the various enzyme. So actually CHA can also be due to deficiency of other enzyme, but the commonest cause is the 21 hydroxylase deficiency. So what happened, 21 OH or the 21 hydroxylase enzyme important to convert the progesterone and also 17 hydroxyprogesterone into 11 deoxycorticosterol and 11 deoxycortisol, which later these are important to synthesize the aldosterone and also the cortisol. So when there is a defect or deficiency of this enzyme, there will be reduction and the production of the aldosterone and cortisol, which can cause in aldosterone deficiency, it can cause a salt losing features, and also the cortisol can later can cause hypoglycemia, which is the emergency in this disease. Okay, and then due to accumulation of these two, progesterone and 17 hydroxyprogesterone, more of this precursor go to the androgen pathway. So they will have androgen excess. So due to the more conversion to the testosterone, that will cause the virilization or the masculinization of the female. There are two forms of CHA, which is the classical form and the non-classical form, which the classical form mainly can be presented in the neonatal period. And there are two subtypes of division of the classical form, which is salt losing and simple virilizing. So salt losing constitute about 75%, and simple virilizing about 25%. So this will the most common cause that cause the ambiguous genitalia in CHA. And however, non-classical form is more commonest than the classical form. And then non-classical form usually appear later and with mild form because they have the adequate and also adequate glucocorticoid and mineralocorticoid production, and usually it is not diagnosed at birth. So for clinical presentation, in the specifically for 21 OH deficiency, so in neonates, female, they will presented with virilized genitalia. So these are the features of virilized genitalia such as clitoromegaly or phallus-like structure. There is displacement of vaginal opening to the urethra, there is a posterior fusion of the labia and scrotalization of the skin of the labia majora and variable pigmentation, and also there will be no palpable gonads. So we have to remember, female there should not be any palpable gonads. So if there is palpable gonad, it might be male phenotype. So for male, in congenital adrenal hyperplasia, it will not affect the external genitalia. So they will have a normal external genitalia with or without penile enlargement. So for both female and male, they will be presented with hyperpigmentation in 90% of the case because of the excess of ACTH in compensatory to low cortisol level. Okay, and then this is worried condition when they came with salt losing features, which can be manifest at the fifth day 5 or 15 life with poor feeding, vomiting, dehydration, hypotension, and also failure to thrive, and also hypoglycemia. So we have to be careful as in non-classical form or in male CHA, they're usually left undiagnosed and untreated, which suddenly they came with emergency situation such as they have adrenal crisis, shock, cardiac arrhythmia, and death. And usually neonatal male with CHA will not survive and usually cause of sudden death in the neonatal period. Okay, so for investigation, so mainly we have to recognize the salt wasting condition. So these are a few investigations that we have to set to look for serum sodium and potassium, renal profile, serum 70 hydroxyprogesterone, serum cortisol, plasma renal level. And also we have to consider other adrenal functions such as plasma aldosterone, androstenedione, testosterone, DHEAS, and there also a role of imaging such as ultrasound to look to detect the internal genitalia such as the uterus and the gonads, the genitogram to delineate the internal genitalia, and also karyotype to look which is it is XX or XY baby. And for management, the general management for CHA is we have to give optimal steroid therapy such as hydrocortisone and prednisolone, and we can also give a salt supplement such as fluorocortisone, and because we know the side effect of steroid therapy to its child, which is regarding the development, so we have to monitor the steroid therapy and regular assessment of the linear growth and skeletal age, and there is a role of surgery if we stage the patient, which is predator staging, to look for the virilization of the external genitalia. If more than 3, it can be considered to do the surgery, and also psychological support. And there are also management for emergency conditions such as in salt losing crisis. Sorry, I'm not touch a bit detail because all this have been mentioned in our PITS protocol. You can read it later. So this is the Prader scale, which is how we want to stage the virilization in CHA. So basically, 0 is when there is normal. Basically, 0 is more towards female, and above 5 is male external genitalia. So we have to look for external view and also cross-sectional view of the external genitalia. Okay, so this is how we approach. So basically, based on our PITS protocol, the main issues that we have to recognize the condition of CHA. We have to exclude in all neonates because it's an emergency situation. So basically, these all points pinpoint towards congenital adrenal hyperplasia, which is the symptoms of salt-wasting during the neonatal period. There is increasing in skin pigmentation, progressive virilization of the external genitalia when there is abnormal pubertal development, family history of congenital adrenal hyperplasia, parental consanguinity because child is autosomal recessive, so we have to be careful, and infertility and also genital abnormalities in family. Again, in obstetric during pregnancy, when during after birth, if there is any previous unexplained neonatal death, such as male with CHA, and also antenatally when there is exposure towards exogenous androgens, and also drugs taken during pregnancy, such as danazol. Okay. So for physical examination, So for generally, we have to look for any facial abnormalities such as internal, short stature, and congenital abnormalities. And also we have to really notice about the psychosocial behavior, such as in older children, they might be feeling inferior, bring shame. So we have to look for the child as a whole. And also signs of dehydration as a salt losing features. So vital sign, we look for the blood pressure, there may be hypertension, and for the skin, hyperpigmentation. So abnormal see for the cloacal anomalies, which is there is a fusion of the urogenital anus, and also the genitalia into one exit. So there may be GI abnormalities associated with the genital development. And for genitalia examination, so we have to really careful doing a genital examination. So look for the size of phallus and erectile tissue. Look for any degree of virilization, position of the urethra opening, and then labial fusion or appearance of labial scrotal folds, and any presence of absence of palpable gonad, such as in female, usually there will absence of palpable gonad, must be absence, and presence or absence of cervix, and usually this is done by specialists during rectal examination, and the position and the patency of anus. Okay, okay. So this is the example. You can see in this picture, the baby presented with empty labial fold, and also there is a phallus-like structure. This is a female baby, XX, and also this is XX baby also presented with ambiguous. There is a clitoromegaly, and this is hypospadias. So these are the criteria which might pinpoint and suggest of DST when there is overt genital ambiguity, discordance between genital appearance and prenatal karyotype, when there is apparent female genitalia with enlarged clitoris, posterior labial fusion in guinal labial mass, when there is apparent male genitalia, bilateral undescended testis, micropenis, isolated perineal hypospadias, sign of DSD, and mild hypospadias with undescended testis. So for investigation, so this is the algorithm. So usually we want to first investigate the baby, which is XX or XY baby, based on the karyotype, such as can we do in the fish as a test, and then next see any palpable gonads. So if gonads is absent, so we have to screen for CHA. However, we don't in Malaysia, we don't have newborn screening examination yet in Malaysia. So and that if present, might likely it is a male baby. So we continue to do the endocrine profile, ultrasound, datagram, and so on. So this basically investigation, like I just previously presented regarding the child examination, and just maybe for anti-mullerian hormone is not really indicated. However, we can send for testosterone, LH, FSH if we want to uh, look for the gonadal functions. Okay, so I think that the rest is just like the same before. Okay, so this is the example of genitogram. So this genitogram showing there is a vagina and also operate a cervix, but also there is abnormalities in the urogenital sinus. And this is the female baby. So for the after we send for the karyotypes and we look for the gonads. So for XY DSD, and then we have a list that we can confirm what is possible diagnosis of this baby. So depending on our finding. So basically, in the first four, one, two, three, four. So this mainly the problem with because there will be no anti-Mullerian hormone. So that's why they can be presented with uterus or with or without uterus. Okay, so basically, the last one because the disorder is under androgen disorder, so they still at the emitting male hormone, but maybe the problem is at the receptor. So these are the algorithm for diagnosis in SS, also as the same as before. We look for the gonads. So there is a list of the various findings that we can found. And mostly they have no problem with the internal genitalia except that in the XX testicular DSD, which is the gonadodysgenesis, when the gonads goes into the testosterone pathway instead of the ovarian pathway. Okay, so for the management, so our goal is to preserve the fertility of the child, and we want to ensure normal sexual function, and we want to make it consistent between the phenotype. We want to improve the outcome of phenotype and psychosocial, concordant with the assigned sex, so they can live happily with their gender. Okay, so generally, we want to admit to hospital because we want to exclude very emergency stages such as insult losing child, which is a life threatening, and then we have to make urgent diagnosis, and we have to really have a good communication with the parents, because we want to advise them for not register the child yet until the final decision is reached. So basically, we have asked them to delay the registry, to register to the birth registry, and we have to protect the privacy of the parents and also the child until we found what is the diagnosis. And yeah, we have to counsel the parents that this disorder is exists, and make them understand and encourage the sorry, eh, encourage the bonding between us and parents and also the child. So for gender assignment, so basically based on the most probable adult gender identity. So based on our diagnosis, and then we have to look the fertility potential of this child, which is mainly about the gonadal functioning, and we have to really examine the adequacy of the external genitalia for normal sexual function, such as in male they must have the adequate pelvic size, for example, and the crown function of the gonads. So this is explaining about the fertility and how they can the capacity to respond to the exogenous androgen. And also we have to really have a supportive role between us and also parents regarding the expectation, the acceptance, and also the socio cultural background. And later we look into the psychosocial development in all the children, like in the future, how they can behave as what gender has been assigned to them. And this decision should only be made by an informed family. So we have really to involve the family in the decision after our careful evaluation, documentation, and consultation. So next, after we assign what is the gender for this child, we give them the appropriate name and appropriate upbringing and dressing. So this is important because family have to really make as if we male assigned, so really dress like a male child, and continue treatment and of the underlying disease. And if there need surgical correction for the functioning, so it can be done. So for the this is the surgery for the assigned female, such as remove all the testicular tissue, vaginoplasty after the puberty, and okay, and then for the male, orchidopexy and remove uterine structure if they have persistent abdominal structures, surgical repair of hypospadias, and can be can also be considered gonadectomy if the gonad is the gonadal dysgenesis. Okay, I think that's all.
Okay, so uh, ambiguous genitalia is a difficult one. The most commonest things that can cause ambiguous genitalia is the female volatilization and also congenital adrenal hyperplasia. And most of them are basically presented during the neonatal period. Um, What was it again? Lupa lah. So every single baby's been born, they normally will be checked by the medical officers before they go home. So checking, we call it neonatal screening, neonatal baby check. They normally check them from top to toes and making sure they are fine. There is no obvious structural anomalies, and obviously, if we suspect the child got, syndromic features, Down syndrome, if you check that there is a congenital hips hypoplasia, you check there is ambiguous genitalia. So you always need to investigate the child before you discharge the child, because you want to make sure that you got the diagnosis before they go home. Most of the children yang ada congenital adrenal hyperplasia, they come with a salt losing ataupun salt crisis, and they can die because of that. So it's very important to make sure you check. And when you're checking and baby before they go home, if they pass meconium, ada dia punya nappy dia dirty with meconium, you want to make sure that you clean the meconium so that you can see the genitalia there, and also you can see the anus there. Because sometimes they might have a coanal atresia, where the meconium is coming out from the vagina, from the penis, and so it's very important to check them. Okay, and sometimes you want to tell parents that if the baby is not passing meconium for 40 hours for three days, then to come back to hospital, because it could be an early presentation or the only symptoms that suggesting of Hirschsprung disease. So those are the things. So we're talking about ambiguous genitalia. So it's very difficult topics to discuss. If the ambiguous genitalia turn out to be a boy, okay. So and then there is no penis, and so and probably there is no testis as well. So it's going to be a difficult one to manage, because if there is no testis but the karyotyping the 46XY, so this boy is not going to function as a boy, meaning that particular baby is not going to have children and so on. If it turned out to be like that, and sometimes people decided to raise the child as a girl. So in that particular case, then the child won't need any hormonal therapy. It's just more towards nurturing the child to be a girl. But the child is not going to function as a girl. A lot of people smile, I don't know why. Yeah. So those are the things. And if you got ambiguous genitalia turn out to be a girl, but dia tak ada ovaries ke, ataupun dia tak ada uterus, so it's the same thing as well. Even though it's a girl, if you do the karyotyping and it turn out to be 46XX, because of the issue with the hormonal, and it turned out that the girl don't have the ovaries or the uterus, then that particular baby is not going to function as a girl. But at the end of the day, it's the family who decided how they're going to raise the child. There's a question before about 46XX baby, but she has non-functional penis, and mana dia punya penis tu nampak macam dia punya extended genitalia looks like a penis, but it's not functioning. Well, the external genitalia is not going to be functioning as a boy anyway. So there's a case where the parents decided to raise a child as a girl. So they do the construction operation, but obviously the child don't have the uterus anyway. So what they did is they structured the external genitalia to be a vagina, but there's no such thing as a uterus. So in that particular case, the child can be raised like a girl, to be nurtured like a girl, but psychologically the child needs to be referred to the psychiatrist, so that she knows that she's a girl, but she's not going to function like a girl. So but the thing is, this is a very rare cases. Even CAH pun, even though it's quite common, but it's not common. And then obviously punsa pun, it's not common. Rarely you see, probably 1 in 10,000 those situations nowadays. But yes, it's a difficult in terms of psychologically. You're going to deal with the lot of emotions. You're going to deal with a lot of because you're probably not dealing, because you're not dealing with the things that happen in there, because you are thinking about things that might happen in next 10, 20 years and down the line, rather than in that particular time. Because if you got CAH, then you just treat the salt losing crisis at the time. But the problem is not just there. The problem will lies furthermore when they are bigger and bigger, and if they survive the teenagers and their childhoods, then it will come more towards the psychiatric and also psychological issues. And obviously there's more cerita pasal Muhammad Sajjad and so on. So those are the things that yang even though she's he, I don't know who he or she is a true transgender or not, but it's not about what or who is she or he. It's about how the netizen, how the people, not netizen, the people going to treat her or or him, because it's a very taboo topics to discuss. Yeah, I don't really have any particular in terms of tips or advice how to deal with that, because it's so complex. There's no such way of saying this is right or wrong, and obviously it's a delicate matters. People say that it is down to aqidah, religion, and so on. But it's much easier to say things like that. This is all aqidah, this is all religion. But when you come to deal with that challenge, it's not easy. Okay, people can talk, but action is so little. Okay, any question about this topic? Okay, if there's no questions, I think everyone to have the very early Fridays. Okay, so I'm going to end the session with Francois.
Thank you, Doctor.
Akilah tu kena keep the distance, social distancing.
Sorry Doctor, tadi dia got kicked out from Google Meet. So we share.
See. Okay, bye. All right. Thank you very much.